Hey everybody, it's Michael, and this is going to be a short video to somewhat add to the content this quarter about inverse ratio ventilation and other puzzles related to some pretty tough ventilator transports we've had over the last little bit. I don't know that our volume is going up necessarily, or the complexity, but it certainly seems like it's persistent related to things both COVID and not COVID, in terms of just how tough some of these patients are to ventilate. So what we're going to go over today are our 3 basic rules of respiratory physiology and how they apply to your ventilator transports and what we're doing, and especially those which are tough to oxygenate. We're going to spend a good bit of time talking about those, and how we manage our oxygenation and what we can do, both with more customary conventional modes of ventilation and things which are a little more complicated, which is going to bring us into a discussion about APRV and U, and the patients you're going to transport who are already on APRV or a similar mode, or the patients who may need something like that because they just won't oxygenate. And that will get us into the things our ventilator will and will not do. It'll do most things. And looking at our Revel mode conversion chart for the ways that we can make our ventilator either exactly mimic the hospital's ventilator, or the way we can make it simulate and get pretty close to what the hospital ventilator is doing, to make sure we can give that patient what they need and the amount of support they're going to have for the duration of our transport. So first we'll start with the rules, and rule number 1 is that we move CO2 with minute ventilation. Minute ventilation is a pretty simple calculation. It's your tidal volume, which is the amount of air you move in and out in a single breath, times your respiratory rate, which is of course how many breaths you take in a minute. So super complicated stuff, how much air you move in a minute. So to change your ventilation, in other words to affect CO2 removal, we're going to change either the tidal volume or the respiratory rate, which is pretty easy to do on the ventilator. And changes you make to the tidal volume typically make a bigger difference than changes in respiratory rate, only because when you make a change to tidal volume, once you exceed the dead space ventilation, which is about 150 milliliters, everything that comes after that is alveolar ventilation. So when you increase alveolar ventilation, you're effectively increasing the surface area at which you exchange gas, which will move more CO2. But here's the rub. Whenever you select your tidal volume, you're going to select a physiologically appropriate tidal volume, which is based on ideal body weight. And you're going to look for a tidal volume about 6 to 8 milliliters per kilogram of ideal body weight. Once you set that, you're usually going to leave that alone. So once you've got their tidal volume selected and it's correct, then to change minute ventilation after that, you're probably going to do that with respiratory rate. Whatever you do with minute ventilation, it's not going to significantly alter your oxygenation unless they're not ventilating at all. So if you have somebody who is in profound respiratory failure that is uncorrected, then their CO2 is going to be high and their oxygen saturation or their PO2 is probably going to be low, just because they're so full of CO2 there's no room for oxygen. So you have to get that out of the way. But once you start correcting that problem, whatever you do to change minute ventilation is not going to help you oxygenate. So I've always said you can't ventilate your way out of an oxygenation problem, and that's true. So whatever you do here, so if you encounter a patient whose O2 sats are low, changing their rate or tidal volume is probably not going to help you. But it will help you move CO2, which is your goal. So, and if you want to target kind of how much CO2 you want to move and what you want to get your CO2 down to, then you can use these 2 formulas. So the first one you see there is your current CO2, whether that's your end-tidal CO2 or your PCO2. This formula is designed to work for PCO2, but if your end-tidal CO2 is high, this will also help you. So take your current CO2, divide that by what your desired CO2, in other words, what you want to get your CO2 down to. Presumably you want it to be normal, and multiply that number times your current minute ventilation. And that's going to give you what your new minute ventilation should be to reduce your CO2 by that much. And since we know we're almost always going to leave the tidal volume alone once it is set appropriately. Then to find your new respiratory rate, you would take this new minute ventilation, divide it by your tidal volume, and that's going to give you what your new rate should be. Now, there are hundreds of different variations that could cause you to have to change this formula. There are going to be times where you need to change both your rate and your tidal volume. Maybe your volume is too high and your rate's too low, and you need to kind of get those to meet in the middle with the same minute ventilation. There's a lot of different ways you can do this, and a lot of different things you may have to tackle, but this will get you started. So we'll do an example in the next slide. So let's say your end-tidal CO2 is 50, which we know is under normal circumstances is too high, and your tidal volume is 500, and your respiratory rate is 12. So the first thing we'll see here is we can calculate our minute ventilation, which the ventilator will do for you, but this one's a pretty easy one. And your tidal volume is 500, your rate is 12. You multiply those together, you get a minute ventilation of 6 liters a minute. Normal minute ventilation is somewhere between 4 and 8 liters a minute. 100 milliliters per kilogram per minute of ideal body weight. Either one of those will get you there, but that's pretty ballpark. So this is a normal minute ventilation, but it's not enough for this patient. They've retained some CO2 for whatever reason, so we need to get rid of that. So applying the formula that we saw on the previous slide, then we see our CO2 is 50. Let's say we want our CO2 to be normal. In this case, there's no reason for it not to be, so we'll say our CO2 is, we want it to be 40. So we will divide 50 by 40, which gives us 1.25. And we'll multiply that times our current minute ventilation, which we said is 6 liters. And multiplying 1.25 times 6,000 gives us 7,500, or 7.5 liters a minute. So that's what our new minute ventilation needs to be. So to get there, we're assuming that our tidal volume is physiologically appropriate at this number. We'll just say it is, just to keep it simple. Then we need a new respiratory rate. So to get the new rate to equal our new minute ventilation, we're going to take our new minute ventilation, 7,500, divide by 500, which is our tidal volume, and that gives us a new respiratory rate of 15 a minute. So 15 a minute times 500 is going to get us to 7.5 liters a minute. Now this is assuming the patient isn't over-breathing that at all, so we're assuming this respiratory rate is 12, combining the machine breath and the patient-triggered breaths. Obviously, if the patient's breathing over that and their minute ventilation is going to be higher, then they're going to work to kind of bring their own CO2 down. You just have to make sure that that's effective and that you're supporting them enough to do that. But these equations will kind of get you there and kind of help you see what you need to do to move that CO2. So that takes us to the next rule, which is we oxygenate with mean airway pressure and FiO2. So FiO2 is going to be the simplest, easiest way to get this started. Now this equation here, one maybe you've never seen before, this is the alveolar gas equation. And we're not going to do this math. I only bring it up to point out that the way that we calculate how much oxygen is available in the alveoli, which of course then is going to be directly available to the capillaries in the lungs, which can then be circulated around, is going to give you your PO2 and your oxygen saturation. We calculate that by taking our atmospheric pressure, we subtract our water vapor pressure in the lungs. So this is going to be about 713 is what that number comes out to at sea level. And the reason I bring this up is because then we multiply that by what our FiO2 is. And so we see we're multiplying a pretty big number times our FiO2, and this is going to be a decimal FiO2. So if you're on 100% oxygen, this will be 1. If you're on 50% oxygen, it'll be 0.5. And then we subtract the PCO2 divided by the respiratory quotient. Respiratory quotient is just the amount of oxygen consumed a minute divided by the CO2 produced a minute, and that spits you out a number which is about 0.8. Again, no reason to get too much into that, but the point is that you're going to subtract this number from this big number over here, and that's going to give you how much oxygen is available in the alveoli. So you can see that's going to be a pretty big number. So on room air, the normal oxygen available in the alveoli is about 99 millimeters of mercury, partial pressure. And most of that will make its way across the alveolar capillary membrane to the oxygen, while we have a resting PO2 of about 100. Okay, so you can see if we increase this from 0.21 from room air, even a slight little bit, we start increasing the amount of oxygen available in the alveoli pretty fast. So that's why you see somebody who has normal perfusion and no diffusion deficits in the lung. That's why you see them, when you start increasing their FiO2, then their oxygen saturation usually comes up pretty fast, because they can move that oxygen across and they do really, really well. Unfortunately, if somebody has a shunt, or they have some sort of diffusion defect in the lungs where they have like some pulmonary edema, some pneumonia, or a PE, something like that, that is preventing them from adequately matching oxygenation and ventilation, then increasing FiO2 is not going to work, and it's not going to work over the long term. So that's where we bring in mean airway pressure. And mean airway pressure is going to be the focus of a lot of what we talk about as we go forward, talking about APRV and inverse ratio ventilation. So our mean airway pressure we calculate with inspiratory time times your peak inspiratory pressure. You add that number to your expiratory time times your PEEP, and you divide all that by your I time and E time added together, which is your total cycle time. And so you can see that if you increase any of these things on the top, you're going to increase the mean airway pressure. So if you increase your inspiratory time, then that's more time spent at the higher peak pressure. Or if you increase your expiratory time or increase your PEEP, that is more pressure spent at this lower time. So as you increase any of these things, your mean airway pressure is going to go up. So the trick becomes, well, what do you increase to do that? So once you have maxed out your FiO2, you've gotten this as high as you can, you've done all you can with that, and you still can't oxygenate somebody, then in terms of what we're going to do, then you're going to have to find a way to maximize your mean airway pressure. And this is really kind of the way you want to go to start with. Typically what we'll do in the hospital is we will work to get our FiO2 down as quickly as possible by augmenting that with more mean airway pressure, which usually means more PEEP. And in most of the patients that we transport, and what we're going to do that with more PEEP. So as we move forward, you'll see how we make those numbers work. So as we have a patient who is having difficulty oxygenating, we're typically going to go with that more PEEP. When I show you the place on that with the reference material that I put out this week, sorry, the dog, the reference that I put out this week, you'll see the strategies we talk about to increase oxygenation by manipulating FiO2 and PEEP at the same time. And real quickly, the third rule is one that's always worth mentioning, especially we had a case in Con Ed this week about a metabolic acidosis, is respiratory drive is most responsive to pH changes. So we often think of respiratory drive going up in response to increased CO2, and respiratory failure being a failure to move that CO2, or a failure to move or increase respiratory effort to respond to that CO2. It's really much more about pH. So the central chemoreceptors in your brain respond to changes in the pH in the cerebral spinal fluid, which is a direct reflection of the pH changes in the blood. And that transmits impulses to the brain like, we need to breathe faster because we got a lot of acid down here that we need to move. And that's going to happen regardless of whether or not your respiratory system can move that acid. So in the case of CO2, of course, that's what it does. It moves more CO2. But in the case of a metabolic acidosis, like DKA or salicylate overdose or some other kind of metabolic acidosis, which is going to be fixed, your respiratory system can't breathe that away, so what it's going to do is going to breathe down CO2 to compensate for that fixed acid. So it's really important when you're treating these patients that you maintain that level of ventilation so that that respiratory compensation stays in place. So it's really important that you don't try to normalize their CO2 because what they're trying to do is breathe away as much as they possibly can to compensate for that fixed acid they can't move. So just always keep that in mind when you're dealing with those patients who have, low pH and a low CO2. They're also going to have a low bicarb, and what you're trying to do there is help them maintain that level of compensation until their metabolic condition can be corrected. So that moves us into what I wanted to talk about in terms of our ventilator and what our ventilator can do and can't do, and the patients that we're seeing more continuously out in the region and in our own facility who are being ventilated with APRV. APRV stands for airway pressure release ventilation, and depending on the ventilator you're going to see, it'll be called either APRV or PCAPRV or something else. So if we see up here in this corner, this is the front face of a Hamilton ventilator, which always calls it APRV. Okay? Down here, this is the front face of a Draeger ventilator, and it calls it PC-APRV. Where it gets a little less clear is like this is the front face of a servo ventilator, and you see it says bivent, which is the exact same thing. There are some different mechanisms on the inside. There's some more limitations on this particular ventilator, but when you see bivent, what it means is it's working just like APRV. And this is the front face of a Puritan Bennett ventilator, which you'll see in a handful of the facilities we go to, and it says bilevel. Bilevel, also APRV. So these all work exactly the same way, and the most important thing about that is that you won't find that on our ventilator. So just a brief description of APRV in terms of that. Again, you'll see it termed as bilevel, bivent. I'm sure there's another name for it out there I haven't seen. When people describe APRV, depending on the educational material that you read, they'll describe it as a type of inverse ratio ventilation or a bilevel CPAP, or you hear it described both ways in some books. And the way it works in terms of refractory hypoxemia, which is where you typically see it used, is it increases the mean airway pressure, as we talked about in rule number 2, but instead of doing it with a high PEEP, it does it with an increased or a longer I time. And in APRV or whatever mode, they always call it T high. So time high, time spent at the high pressure. And so you'll have a much higher pressure than you would normally see in that particular phase, and it's held for a much longer time. So typical our T highs in APRV can be 4, 5, 6 seconds. And again, it's used for refractory hypoxemia, and you'll also see it used for lung protective ventilation. So for those of you who transport patients out of 3 North to go to long-term care facilities like Life Care or PAM, they call it now, you'll see almost all those patients are going to be on APRV, and they use it up there for lung protection. And it works really, really well for that. And I'll explain why. So, describing APRV as inverse ratio ventilation is a little disingenuous because it's not exactly true. The way it differs from traditional inverse ratio ventilation is APRV features a release valve, which is where the R comes from, which allows the patient to breathe over top of those pressures during the entire respiratory cycle. So the patient's going to spend, during a typical cycle, it's going to spend 5 seconds at the high pressure, the P high, and then they'll spend, half a second, sometimes less, at the P low. But the patient can breathe over that the entire time. That's what kind of makes it like bilevel CPAP. So they'll spend 5 seconds at the high pressure, say of 25, and they can be way higher than that, and they'll spend half a second at the low pressure, which is usually 0, and they are breathing the whole time. So the way the ventilator cycles is asynchronous from the patient. The patient doesn't trigger the ventilator like that. What they do is they can just breathe during that phase, irrespective of what phase the ventilator is in. So that's kind of what makes it like the bilevel CPAP. If the patient doesn't have any respiratory effort, if either they have no effort or they're paralyzed and sedated, then APRV works exactly like inverse ratio ventilation. Your I time is just longer than your E time. So that is the way that we can kind of mimic that with our ventilator, because of course our ventilator lacks a release valve. So the patient cannot breathe during the expiratory phase of inverse ratio ventilation through our ventilator. So if they try to use it exactly like APRV, it's not going to work, and it would be tremendously uncomfortable for the patient. So that's why, in a second, we're going to talk about how this is reserved for the sickest, most difficult patients to oxygenate. So Our ventilator is capable of doing inverse ratio, but in a very restricted way. So it's quite different from the ventilators you're going to find in the hospital. So if you're going to set up our ventilator to do inverse ratio, then you're going to do it the same way every single time, and that's because of the limitations of the ventilator. So first two things, you're going to want it to be in pressure control and assist control. So if you remember from the sheet you have, from what you've learned before, pressure control, you're going to set an I time and a peak pressure, or a pressure control, and the ventilator is going to hold that amount of pressure for that amount of time. And when you make it assist control, that means if the patient were to trigger, which they're not in this case, then they would get another breath just like that. So, and then we're going to set our rate at 16 and our I time at 3 seconds. And the reason for this is because the limitations for the ventilator, it will not allow you, no matter what you do, no matter how you set it up, it's not going to allow you to set an I ratio any greater than 4:1. So even if you were to try to set like the rate lower and the I time to be longer, it's still going to lock you out from doing anything greater than a 4:1. So what this does is it allows us to set the longest I time possible and still have a reasonable amount of ventilation. Because that expiratory phase, which is going to be super short, in this case our I time is going to be 3 seconds, our expiratory time is going to be 0.75 seconds, so really, really short. But that 0.75 seconds is going to be where any of our ventilation takes place. So when you're setting this up, plug those things in there. You're also going to want a PEEP of 3, and you're going to leave that alone, because the PEEP of 3 is kind of a split in the difference. So if we were to take our PEEP all the way to 0, during that 0.75 seconds, we would completely de-recruit, and you'd have to re-recruit every single time. And what we know about lung injury, especially ventilator-induced lung injury, is that when you have cyclical recruitment and de-recruitment of alveoli, this is where a lot of lung injury takes place, especially in adults. And so we don't want our alveoli to de-recruit, and we'll also deoxygenate when we do that, so we don't want to do that. However, we can't have our PEEP too high, because if we had it too high, then that would restrict what limited amount of ventilation we're going to have. So PEEP at 3 is kind of the best way to split this difference, and we're going to put it at 3, and we're going to leave it there. And then when you're setting your pressure control, you can do this a couple of different ways. So if you encounter a patient who is already on bi-level ventilation at the outside facility, they're on APRV or bi-level or bi-vent, depending on their machine, look and see what their P high is, and then you're going to use that as your pressure control number for our ventilator. Now, side note, remember that when you set pressure control on our ventilator, that number is added to the PEEP to give you your total PIP. So when you look at the P high on the referring ventilator, that's the total pressure. So that's as high as the pressure is going to get. So if their P high is set at, say, 25, then that's as high as the pressure is going to get. So every time that APRV breath cycles to the T high, it's going to be there for that amount of time, and it's going to be at that pressure, say 25. Okay. So if you want to duplicate that on our ventilator, then you would want to set a pressure control of 22, because you're going to add that number to our PEEP, which you know is going to be 3, and that's going to give you a total pressure of 25. So always remember that on our ventilator, or basically any ventilator where you see the setting pressure control, that number is additive to the PEEP to give you your total PIP. So you can select whatever their P high is and use that. If they are not on that yet, you would just look and see what their peak pressure is. If it's making their chest move, which is what you want, then you can start with that number. If you're not starting with anything and you have trouble oxygenating them, you can start at the default pressure control on our machine, which is 15, and then titrate that upward until you get their chest to move, their good chest rise, and you're getting an adequate exhale tidal volume, which would be about 6 to 8 milliliters per kilogram of whatever their ideal body weight is. And then after that, you're going to titrate your oxygenation with your PIP, your pressure control number, because that's how you're going to get them to oxygenate, is by increasing that pressure. And some of those pressure can get kind of high, especially if patients get really, really sick. which is, again, is why we reserve this for the sick patients who just won't oxygenate any other way. So, our pearls, these are just the things you want to think about every single time before you decide to do inverse ratio. And as you're doing inverse ratio, is the very first thing is decide you've done everything else you can before doing inverse ratio. This mode is not free, it is not without side effects, it is not without complications, and it really should be just about the last thing on your list of how to oxygenate a really difficult sick patient. Think about if you can cut the rate down some and increase the PEEP some more, increase the I time some more, everything you can do to really maximize the mean airway pressure and get the most out of that mean airway pressure equation to see that you can oxygenate some other way, that you've done everything you can before switching to IRV. Secondly, once you've decided that you are going to and you have to do inverse ratio, understand that you have to sedate and paralyze that patient before and then for the duration of the inverse ratio ventilation, so for that whole transport. If they trigger the ventilator, then that's going to disrupt the ventilation and almost assuredly lead to deterioration and decompensation. Again, this is the one way that this mode drastically differs from true APRV is we don't have that release valve, so the patient can't breathe over the scheme that we have plugged into the ventilator. And so if they try, or if they're able to because they're not properly sedated and paralyzed, then as they trigger, it's going to really screw up the way that the ventilator is going to work. So we can't let them do that. So every single time you're going to have to do that. Third, really adjust your expectations for what oxygenation is going to look like. Ideally, for most patients, we like to see an oxygen saturation of greater than 94%. That's probably going to be a bridge too far here, and getting to 90% is probably going to be about the best we can hope for. When you get to that bedside, see what that patient is oxygenating on the hospital ventilator settings, especially if they're already on APRV or on bi-level or on even inverse ratio. And if the best they're doing on their hospital ventilator is 88%, then that's probably the best you're going to do. So don't drastically increase the peak pressure trying to get to a normal oxygen saturation, because you're probably not going to do that. I mean, that's why we started this mode in the first place, is because somebody was really sick and really poor oxygenation, and so managing our expectations of what that's going to be means something less than that. As a side note, it's not on the page here, but it's worth talking about, is make sure you don't run out of oxygen. When you get there and you decide you're going to have to do this mode, find a way to plug in to the hospital oxygen supply at the bedside so that you can have a good long time to get this set up and make sure the patient's going to do well on our ventilator with this mode. And then make sure you have plenty of oxygen for every step of the way after that. Make sure you got plenty of tanks to get you from the hospital to the aircraft or the truck, and then make sure you have obviously plenty of oxygen in your vehicle, and then make sure you have plenty of oxygen when you arrive at your destination. That may mean taking the hospital's oxygen tank outside with you until you get loaded up, and that may mean having somebody to bring you a fresh tank on the upper pad, or more than one, to get where you're going. So the last thing you want to do at any point in this evolution is run out of oxygen, so make sure you have planned that out well ahead of time. Keep in mind your settings for this, particularly your rate, your inspiratory time, and your PEEP are going to be fixed. So you're not going to change those things. So the things we may have done in the past to further help our oxygenation situation, we've done all we can with those by switching to IRV. So you're going to manage your oxygenation now with your peak inspiratory pressure. And again, keeping your new target, your new expectation in mind, adjust your peak pressure upward, usually by 1 at a time, to try to increase your oxygenation. And you really kind of want to do that before you leave the referring facility if you can help it, while you're sitting still and you got a second and you can really take time to find out what that number needs to be to get your oxygenation where you want it or the best you can get it. Because your rate especially and your expiratory time is going to be fixed, some degree of hypercapnia is to be expected with this mode. So your CO2 is going to go up. because we're pretty seriously restricting ventilation for the benefit of really trying to maximize our oxygenation. So it's not uncommon that your CO2 is going to climb, which is one of those things you want to really keep in mind and think about when you get started. So if you start out with a fairly normal CO2, then you've got some room for that to go up, and you can expect that to climb above normal during your transport. If you start with really low oxygen saturations and really high CO2s, then understanding that your CO2 is only going to go up from where you start, that may need to be a phone call to medical control and really do some other planning about how you're really going to get that patient out of there and do it safely, because there's a possibility that the CO2 may climb so high during the transport, if you start really high, that's going to be unsafe for the patient and for you. So think about that. Really look at a blood gas, look at an Untitled before you get started, and see if you've got room for the CO2 to go up that high. And if you don't, then again, you want to get on the phone with medical control, just kind of tell them where you are, get on the phone with the supervisor, kind of tell them where you are, and that maybe you can't do this. Another thing that's going to go up during the transport is intrathoracic pressure. So we know that as we start to increase PEEP, then that pressure is retained in the thoracic cavity and intrathoracic pressure goes up, which we also know leads to a decrease in preload and an increase in afterload and a decrease in cardiac output. All those things contribute to poor hemodynamics. So hypotension and other hemodynamic compromise is common with patients being ventilated like this. So the same is true of patients in inverse ratio ventilation. So as you keep going with the transport, you may see the blood pressure begin to drop. Real important thing here is that instead of trying to decrease the intrathoracic pressure by changing your ventilation in hopes of increasing the blood pressure, then what you really should do is leave your ventilation like it is if it's working to increase and improve your oxygenation, and then support the blood pressure, whether that's through fluid boluses, vasopressors, whatever you need to do to make that happen. These patients are super sick, obviously, so you're going to have to manage all different facets of them to keep them oxygenating, ventilating, and perfusing. Also, really work to avoid circuit breaks. In the times of COVID, we've done a really good job about being disciplined about transferring from the bag mask to the ventilator, from one ventilator to another, to where we're really avoiding circuit breaks, and we have to break the circuit. We're clamping the tube and doing all those things. Not only does that help to limit the spread of infection, it also helps to limit de-recruitment. So every time you break that circuit and you let all that air or all that pressure come out, then all those alveoli collapse and you have to work really hard to re-recruit them. So everything you can do to avoid circuit breaks is going to be helpful. One of the things I always recommend to folks is if you go to a hospital and they're already on the ventilator, most places we go, they're going to have an inline suction catheter on that vent circuit. I would take that with you. That way, if you need to suction during the transport, then you've already got that in there, and you don't have to break the circuit to put a suction catheter down the tube. You've already got one there. So little things like that are going to help this patient stay good and oxygenated as best you can, given all the other circumstances. And finally, with something like this, it's going to take your time. You're going to have longer bedside times. You're going to have just much more time in planning and thinking about how you're going to take care of this patient once you've decided that you're going to go down this road. So just keep that in mind. Just take your time and just be really thoughtful about what you're doing as you go forward. So with that said, we will revisit our Revel mode comparison chart. There's a more updated version of this coming out. As we said before, the Revel is capable of many of the modes you're going to see in hospital ventilators. It's just a matter of understanding the language. So there's a lot of different words that mean the same thing in ventilator speak. So the purpose behind this reference is to kind of bridge that gap for you. And it's updated because I had left a couple of modes off, and so we added those back. But otherwise, if you have the older version, you're 99% covered. And this is perfect size. When you get the picture file to put on your phone, again, you can just scroll right through that. You can convert it in such a way where you can put it on your badge or put it in your pocket or wherever it is you keep your references. But This is just an easy way to find what the hospital mode is and then compare that to what our ventilator is and what it will do. So here's an example. If you look on the referring ventilator, so you can see up here in the corner, this is a Hamilton G5. So up in the corner you see it says S in parentheses CMV. What that is exactly is volume control ventilation. It's volume assist control, which is how you would duplicate that on our ventilator. So if you were to look down on our piece of paper, you would see beside of SCMV, you see it says volume AC. And so then you could take their settings, which are here, and put those in your ventilator, and it should do exactly the same thing. Now, the cool thing about that is, and the way this little reference is made to work, is you don't have to know what kind of ventilator it is. It does not matter. Absolutely does not matter one little bit what kind of ventilator they are using. All you have to do is find this language right here. So in this one it's up here, and some of the ventilators it's going to be in this corner. Some ventilators it's down here in the bottom. If you don't know where the mode is for the particular ventilator, just ask the therapist there at the bedside. They'll tell you. They'll be able to find that for you. And the other thing about that too is keep in mind that just because they're on a certain mode on that ventilator doesn't mean that's correct. That may need to be changed. It may need to be different. So if you look at what they're doing and it's not working, then it's okay. You can find what their mode is, but you may need to do something different on yours, which means you'll just kind of punt completely away from this. But if you're in doubt about anything, about the settings, about anything like that, say, hey, your ventilator's working great. What mode is that? Cool. They'll tell you, and you can look on yours, and you'll see this is what we need to do to fix that. If you want to go back a few slides, you remember our ventilator doesn't have APRV. So if you find them in APRV or by level or by vent, that's on there, and it'll kind of tell you what you need to do to duplicate that. And then if you need to be in inverse ratio, then you can refer to that other reference, and it'll show you how to do that. So we've really tried to cover you as best we could for all those situations, but there's no way to cover it all, and we're working on a mechanism to kind of help with real-time vent consultation, and that'll be coming out later. So the two things which you're going to get this week in Con Ed, and which will be available to you electronically, are the updated mode conversion chart and also the clinical adjustment guide for this year for the Revel. This is a two-sided document that's got our most important rules for respiratory physiology are on the front there, how to use the mode conversion chart, how to set up and mimic bi-level ventilation on our ventilator, in other words, how to set up inverse ratio. And on the other side, it's got just some basic tips for initial vent settings, how to set the ventilator up to do what you want it to do, how to correct problems, a lot of things which are somewhat a review, some of it's new, but just a real quick update for this year about how to manage your ventilator and what you need to do to fix certain problems. So, in summary, again, know the rules. If you understand the rules about how to oxygenate, how to ventilate, and how to respond to pH changes, then setting up and running the ventilator becomes pretty simple, as long as, again, you know what your goal is. Know about inverse ratio ventilation, know how to do it, keep that reference handy, and remember, the most important thing I can tell you about inverse ratio ventilation is it is almost a last resort. If you just can't oxygenate somebody any other way, then while you're thinking about doing an RV, you should probably also be thinking about getting on the phone and saying, this is where I'm at, this is what I'm stuck with. Do you have any other suggestions before I go to this next thing? And finally, our ventilator can probably do what you want it to do. Between looking at that reference and looking at the mode conversion chart, and kind of tell you how you want to do, or how you can do what you want to do. It's just a matter of understanding the language and understanding how our ventilator translates those things from other ventilators. That's all I got. By all means, if you got any questions, you can send me an email, give me a call or a text. I'll be more than happy to help you. And if you have any questions, let me know. Thanks.